and really I'm calling this Achieving Health and Equity for Women, Building on Success and Power of Our Movements. So I want to start with what I believe. I believe that equity in health or in life depends upon strong and well-implemented public policies, that every person should have the freedom to decide if and when to be a parent and have a family. I am a person who decided not to be a parent, not to have a family. I respect the wishes of all others. That reproductive justice will be attained when all people have the economic, social, and political power and the means to make decisions about their bodies, their sexuality, and their families. That our challenges won't be remedied by clinical practice changes, quality improvement, or individual behavior change alone. That to have equitable impact on the greatest number of women, children, and families, we must ensure effective and equitable public policies, programs, and services, and that the data are not now, nor have they ever been neutral. And thanks to Nancy Krieger for always reminding us of that. And I realized during the last session that this year is my 50th year on working on women's reproductive health and now reproductive justice. So I want to talk to you a little bit about advancing health and equity in the past 2 decades, about movement and evolution. And the next series of slides, there's going to be a set of things that are having a list of names down the left-hand side. That in some ways reflects my own experience. In some ways it reflects publications. It is certainly not a list of everyone who helped to shape the vision of the topic I'm talking about, but it's a sample, and it reflects, gives you an idea of the array of people and honors some of those who have contributed. We started out, and I'm just going to put the anchor at the 2006 recommendations that were reaffirmed in 2011 and 2014, where we said preconception care aims to promote the health of women of reproductive age before conception and thereby improving pregnancy-related outcomes. After the recommendations were published, I was the lead staff on the initiative and a co-chair of the panel, and I began to say it this way: to improve the health of women and any children they may choose to have. So we had 10 recommendations. They are broad categories. There were sub-recommendations and specificity under that. You can see the first one starts more with the individual. There's a cluster in the middle that have to do with care and the system of care. And then we got into public programs and research and monitoring on the end. This is a set of the milestones at the time when I was one of the leaders of the initiative, and we did a lot of work. We did 3 journal supplements. We issued national recommendations. We had work groups on clinical public health, consumer policy, and research issues. We worked on data sets and worked with a lot of organizations to build up visibility of the issue through them. We worked in 27 states, which doesn't exactly show on this slide. And then around the time that UNC took over as the backbone organization for the Preconception Health and Healthcare Initiative, I'm flipping a little bit back before 2014, as the headline says, but we had the Affordable Care Act coverage. We had a strategic action plan implementation, more work by CDC on getting a solid set of indicators, and the Show Your Love campaign, which many of us are now familiar with. The toolkit at Before and Beyond, the periodic practice bulletins, updates on indicators, and what we're honoring today, the Preconception Coin, funded by HRSA and launched with Straight Teams and many of the rest of us involved, a book, thanks to Sarah and her authors, on preconception health and healthcare, and a very important article on evolving the preconception health framework this year. Again, shaping the vision for well woman care has been going on a lot at the same time. A list of people there who have been visible leaders in this effort, but not everyone. And my apologies if you're a leader in any of these and I didn't put your name up. And then Senator Barbara Mikulski, because she was the reason that we ended up with women's preventive services in the Affordable Care Act. Thank heavens for that. And so that aim to do every woman, every time, attention to the life course to women's wellness, to have a content of care defined by experts where it had not been before, to have federal guidelines reflect what experts determined was appropriate and have periodic updates with a focus both on reproductive health that was particular to women as well as their health overall, a recognition that access and quality varied by race, ethnicity, income, and insurance status, and a recognition of the power of guidelines and their implementation. So on August 1st, 2012, almost a decade ago, 47 million women who had insurance got coverage for a package of women's clinical preventive services without cost sharing. That includes well woman visits and preconception care. And Diana Ramos is later going to talk to us about the Women's Preventive Services Initiative, which is an outgrowth of that effort. But I want you to be thinking about how we could drive more effective implementation of this coverage. We've had an initiative called Bridging the Chasm Between Pregnancy and Health over the Life Course that came out with a national agenda publication this year, and you can see the names of those people who are co-authors on the agenda, but there were more than 70 stakeholders who came together across this process and talked about a 6-point priority agenda about eliminating institutional and interpersonal racism in health institutions, about infrastructure support for community-based organizations, team-based care on a holistic basis, expansion of Medicaid coverage and Medicaid performance, systems to preserve maternal narratives and data across providers, and an alignment of research with women's lived experience, a really broad set of issues that it'll take that and more, obviously, to bridge that chasm. We have a group of leaders who've been shaping the vision for reduced maternal mortality and pregnancy-related deaths, and you can see the names of many of those and some of those who are with us today, and I've included celebrity Serena Williams for her visible role in all of this. But again, if your name should have been on there and I missed you, I apologize. It's a sample. This movement has been accelerated by Black women, particularly in medicine and politics, and it includes members of Congress, national experts in public health, leaders, and an array of private organizations such as the Birth Equity Initiative. And they've been calling for an end to excess and preventable pregnancy-related deaths among Black birthing people, expanded Medicaid postpartum coverage, improved access and quality with more culturally congruent, unbiased workforce, to having those care teams, again, those will come up again and again, and addressing structural and institutional racism. And we have those who've been shaping the vision for reproductive justice over decades with, again, an accelerating pace of this movement and its visibility. I worked many, many years ago, back in the 1980s, with Billy Avery, who taught me a lot about this before we had this wonderful term for it circulating so widely. And you heard earlier Sarah and others on the first panel talking about the human right to maintain personal bodily autonomy, have children, not have children, parent children in safe and sustainable communities, to think beyond the limits of reproductive health and the reproductive rights movement, which was more about contraception often, to understanding intersectionality, to centering the most marginalized, and to addressing historical and current systemic racism in policies and in practices. So that leads us to the evolution of this preconception health concept. So from that article I mentioned earlier, talking about how the movement in preconception health advanced our understanding, but since that framework emerged around 2006, the social movements and changes within our healthcare system have changed our discussion. There's an increasing discussion about the importance of and barriers to reproductive and bodily autonomy, the relevance of structural inequalities and social determinants of health, and the need for greater attention to gender and race equity, which in turn points to the opportunities to involve the preconception framework to center gender and race equity, as well as to recognize the multidimensional and intersectional context in which reproductive health outcomes occur. And I think as we're here today to talk about future forward, we've got to take this to heart, and we've got to think about how our work reflects this future direction and evolution. So many of you know that famously Maya Angelou is quoted as saying, do the best you can until you know better, and then when you know better, do better. So I would say now is the time We know better, so let's do better to improve women's health. This is a time to go farther to do better. What we have done in the past has often been our best effort, but it's been limited by incrementalism, by the socio-political context, by not reflecting women's voices and not acknowledging and addressing bias and racism, and not sharing power with women, families, and communities. There are a lot of data about unequal treatment. These are from a Kaiser survey, and I'm not going to go through the details of this, but if you look on the left, it's by insurance status, and what you can see is for these topics about whether or not the provider gave the woman counseling about these sexual health topics before she was pregnant in a routine visit, you can see that the privately insured women got more on contraception and sexual history, but then the Medicaid women were asked more about HIV and sexually transmitted infections. That, to me, is a reflection of bias. And if you look on the right, the examples where, again, for the Black women, getting less on contraception but then, you know, thinking about how the white women not asked so much about their sexual history, whether or not they have exposure to HIV or STIs. Again, to me, a reflection of bias. I'm going to pick up on this graph on the right. This is from PRAMS. This is a data about preconception advice and services. I want you to notice the scale is only 8, so it's not like many women are getting this at all, but you can see that if anyone's getting it, it's more likely to be a white woman. And this is another thing I want to say about these data and the PRAMS data. We are often using our data from PRAMS that focus on women's behaviors. Did she smoke? Did she do this? Did she use drugs? Did she do that? We're not often focusing on the data in PRAMS that tells us about unequal treatment. And we need layers of change, recognizing the role of racism in access to care for Black, Indigenous, and other people of color, improvement in coverage and benefits, implementation of practice guidelines. I've just shown you 3 slides where we can see that practice guidelines are not uniformly being implemented in the preconception period by race, by income, by insurance status. The adoption of anti-racist and anti-biased approaches by all types of providers, shared decision-making and patient-centered care, and the design of quality improvement approaches that focus on equity, not just measure disparities at the end of a generic process. So what's the context for our policy and programs today? Childbearing people need basic supports like family leave and income support to offset social determinants. We need to assure access to quality and equity in the care across the lifespan. The Affordable Care Act has been very important. It has to be better protected and implemented. Medicaid expansions are needed, they're essential, but we also need Medicaid performance to improve. The Title X family planning is critical for low-income women in particular, but it's often threatened. Community health centers are serving 1 in 10 low-income women with a full range of primary care across the life course, but we don't give them very much of our time and attention in terms of improving the care that is being delivered there. The Title V Maternal and Child Health Block Grant is in every state, but it's often underutilized for women's health, and access to abortion is threatened by judicial and legislative action and is already more limited for low-income women, particularly those covered by Medicaid. So I'm not going to spend a lot of time on this slide. I just want you to focus your attention on, first on the left, that the green is Medicaid, and that 40% of low-income, non-elderly women are covered by Medicaid. And over on the right, in terms of citizenship, that 1/3 of the non-citizen non-elderly women do not have health insurance. You can see an array of flow in between, but particularly in the middle, the role of Medicaid for women of color. Medicaid has a lot to do with financing women's reproductive health. It's the single largest source of public funding for family planning. It far overshadows the scale of Title X, which is more important in terms of infrastructure. But whether we're talking about the family planning and preconception services financed by Medicaid, the prenatal services, the birth services, the postpartum and interconception care services, not all of the things listed are uniformly provided, so we don't have equity across states. And we don't have Some things that we really want, like infertility tests for these low-income women, only covered in 9 states, doula services in a handful of states. Interconception care for high risk, we've worked with more than a dozen states, but we don't have a good model out there yet. A lot of us are focused on expanding Medicaid postpartum coverage, but we've got to make the whole continuum work and deliver the care that women need and deserve. And when there are birthing people who are in Medicaid, and it's half of the births are financed by Medicaid, we really need to make that system work if we're going to ensure equity. I want to talk for a moment about the role of Title X family planning in preconception health. Obviously, core family planning services, including reproductive life plans and family planning methods and services, as well as pregnancy testing and counseling, are really an important part of preconception health. But they've made a commitment to more, such as offering basic infertility services or STI and HIV testing, counseling, and referrals, and screening and referrals for substance use, as well as other things that you see here on the list. And I'm really impressed. If you go to look at the Office of Population Affairs website, you will see their commitment right now in this administration to assuring quality that leads to improved reproductive health outcomes and overall optimal health. So really, they are thinking about this health and wellness aspect and their role in it. There are more than 24 bills introduced in this session of Congress about maternal health, and a similar number introduced in the last Congress. When you download the PDF of my slides, you'll get a complete list of the pending bills, but I wanted to show you the buckets. So there's a coverage bucket, particularly about Medicaid expansions, but also emphasis on things like immunizations and dental care and the comprehensive nature of the benefits. Quality, whether it's quality improvement collaboratives and data, or workforce expansion and training, or new innovative payment models or care coordination models, and grants to states to implement best practices such as those about AIM, which Christie is going to talk about later. And then there's a focus on social determinants of health, which calls for an interagency task force and an array of topics, including climate change and incarceration and the other things you might typically associate with social determinants, and reports from a variety of agencies, as well as direct grants and technical assistance to community-based organizations and programs that have long been doing the work. We heard the first panel calling for that. There's money in the Momnibus for that. So I want to just say we need to be working across the life course continuum. We really need, some of us are focused on one aspect of this or another, and there are a lot of connectors between the items that I put up here as just forces on the continuum. But if we want women's wellness across the life course, we need to think about the full array of these things and how these various aspects fit. As Sarah Berbice mentioned earlier, you know, good to focus on this postpartum coverage, but are we going to get back to focusing on well woman care and focusing on the woman herself and her own well-being across the life course continuum? So I want to thank you. And that's me when I was 18, and I was a young community activist in reproductive health and needed a lot of family planning services from a Title X clinic. And I honor the girl that I was in doing the work that I continue to do. So I'd like to introduce the panelists. I'm going to introduce all 4, and then we'll begin with the panel. We are really honored to be joined by Dr. Diana Ramos. Dr. Ramos is the Assistant Deputy Director for Chronic Disease Prevention and the Center for Healthy Communities at the California Department of Health. She's also an adjunct assistant professor at the Keck University of Southern California School of Medicine. Dr. Ramos serves as the chair of the ACOG District 9, which includes California. She serves as the co-chair for the Women's Preventive Services Initiative Implementation Committee, and she's on the executive board of the National Hispanic Medical Association. Her areas of expertise include child health, social determinants of health, wellness, quality, improvement, and Dr. Ramos has contributed to numerous articles, lectures, and in both Spanish and English, and her recent awards include the 2020 University of California Irvine Latino Excellence and Achievement Award, the 2018 National Hispanic Medical Association Fellow of the Year, and an ACOG District Service Award. She received her medical degree in OBGYN training from the University of Southern California. She received her MBA from the University of California, Irvine, and her master's in public health from UCLA. Christie Allen is the Senior Director for Quality Improvement and Programs at the American College of Obstetrics and Gynecology, where she provides clinical support to and supervision of the Alliance for Innovation on Maternal Health, known as AIM. Prior to this role, Christie served as the Associate Director for Clinical Quality for ACOG, as a Quality Coordinator for a Planned Parenthood affiliate, and as the coordinator of a statewide Medicaid program for people with substance use disorders and pregnancy. In the clinical part of her career, Christie practiced as a clinical bedside nurse for over 20 years in adult pediatric, NICU, and inpatient obstetrics, as well as a lactation consultant, and she holds an advanced degree in health policy. Lakeisha Daniel Robinson has 20 years of experience in collaborating with healthcare organizations and federal and state entities. As the Director of Maternal and Child Health Services at IBM Watson Health, she leads technical assistance and change initiatives focused on improving outcomes, delivery, and access in maternal and child health. On behalf of the Centers for Medicaid and Medicare Services, she leads efforts to improve the capacity of Medicaid and the Children's Health Insurance Program. She co-chaired the National Quality Forum effort on maternal morbidity and mortality, and which was charged with developing a measurement framework to focus on short and long-term strategies to measure maternal mortality and morbidity. And prior to joining Watson Health, she served in the Division of Quality and Health Outcomes at the Center for Medicaid and Medicare Services. And in that role, she led the launch of the Maternal and Infant Health Initiative. A lot of her work is well known to you. You just didn't know she did it. She did it quietly as a Fed. And Naomi Clemens is a Senior Technical Advisor at John Snow, Inc., and her work at JSI includes family planning, maternal child health, and other topics. Naomi has over 20 years of experience in the field of MCH, and her work focuses on addressing the drivers of health disparities that perpetuate poor outcomes experienced by women, children, and families. Much of her work supports national initiatives, supporting systems improvement and change that promote community-driven and centered strategies. So thanks to you all. I turn it over to Dr. Ramos and the video.
Great, thank you so much, Kay, for that wonderful background. And I am honored to be here with my esteemed panel and to be able to share with you information on WPSI and really understand what a critical role we all have in helping expand women's health through WPSI. So let's get started. I thought for those of you who are visual learners like me, a video would be a great way to start. So I will turn it over to our tech masters.
Clinicians work hard to provide the right preventive care. Because when women are healthy, communities thrive. And yet, nearly half of the women in the US are not receiving the life-saving preventive care they need. Clinicians often don't have the trustworthy and efficient tools and resources they need to prioritize care for patients. Understanding these challenges, we developed the Well Women Chart, an easy-to-use summary of preventive services recommendations based on age, health status, and risk factors. The Well Women Chart outlines recommendations by the Women's Preventive Services Initiative, WPSI, along with the U.S. Preventive Services Task Force and the American Academy of Pediatrics. The WPSI was launched by HRSA and ACOG to develop comprehensive, cutting-edge, and evidence-based recommendations that fill critical gaps in women's preventive services guidelines. Our trustworthy recommendations address pressing and often overlooked health needs and help increase access to quality care. The WPSI's recommendations are based on a rigorous review of evidence and collaboration from a broad coalition of healthcare experts. Use the WPSI's recommendations and Well Women Chart to address preventive health needs at every age and stage. Because when women are healthy, communities thrive.
Thank you. So that was just a quick, brief background on what WPSI is. When we've done surveys with other meetings, we find out that up to 80% of our audience members don't know what WPSI is. So I am making you all WPSI ambassadors today. This is an initiative that really can change the playing field for women's health. We can not only promote quality care, but more importantly, help improve equity among all women of all ages, races, ethnicity. The QR code behind me, I highly encourage you, and I won't be offended if you click on there, and you're going to actually get to see what WPSI is all about. And it is a wonderful resource for recommendations for health, preventive health services from all across the ages. So from adolescents all the way to postmenopausal women. The beauty about WPSI is because they're HRSA-backed recommendations, they actually qualify for reimbursement. So for your healthcare provider, many times we hear, we want to be able to provide the care, but one, we don't know what it is, and two, how can I get reimbursed? Well, this is where WPSI really fills that gap. So I encourage you, take a look at it. And there was another slide, I don't know if we can continue on to it, but you're going to see that because WPSI spans the life course of women's health, we really are making an impact not only on the current generation of women, but on the future generation of women. For those women who choose to become pregnant, their stress, everything that they bring in their being to their next child, if they choose to, is going to impact their health. And this is where WPSI, here it is, plays a role. And again, I'm a visual learner, and you saw it's preconception health going on to prenatal care to wellness and health in general. But the most important thing is that if a woman chooses to become pregnant, I heard the conversation, definitely, it's not a choice for everybody. But the one big important thing to realize is that we are promoting then healthy families and healthier communities. If I can have the next slide. And here you are, this is what that Well Women's chart is. And really the critical piece is that it's available for everyone to see. It's on the website there, womenspreventiveservices.org, womenspreventivehealth.org. Go on there, share with people that you interact with, and let them know this is a recommended preventive service for you. And the final piece that I will leave is that we are in our second cycle of granting. So we received a 5-year grant, and now it's just been renewed. And there's an opportunity to make a difference in what is going to be covered. So for all of you who are saying, how can I make a difference? This is it. Go on to the website. And right now there's open comment period for breastfeeding services, for counseling for sexually transmitted infection, and for overall Well Women preventive service visits. So we want to hear the comments, because this is what's going to be used to say, yes, we want to continue with this preventive visit or whatever the service is, or not. And then if there is something else that you feel that should be covered for women, it doesn't matter, the age, whether it's reproductive age, postmenopausal, women who are older, please let us know. You can actually provide that input. So this is your opportunity. Help us out, promote Women's Preventive Service Initiative so that we can promote health and really level the playing field for everybody. Help us make health the women's health an equity area, because once we have the standards, nobody can say, I don't know. It's going to be a matter of promoting. So thank you for the opportunity to share about what the Women's Preventive Service Initiative.
Diana, thank you so much. We all need to know more about it, and we all need to follow your progress. And thank you also for staying on time, so we have room for the other panelists. Okay, let's go next. Christie.
Hi, thank you so much. My name is Christie Allen, and it's an honor to be here today in such good company, both the attendees and the panelists. I am also with an ACOG-based program. It's known as the Alliance for Innovation on Maternal Health. We're going to call it AIM, nice and short. The AIM program was implemented in 2014 and is now in its second cycle of funding. It is a cooperative agreement between the American College of Obstetricians and Gynecologists and HRSA, and it is a federally funded program focused on reducing preventable severe maternal morbidity and mortality across the United States. It started as a relatively small program. The goal was 8 states. We now have 41 states and the District of Columbia enrolled in the AIM program, and we expect to have all 50 within the next year or so. AIM works by working with state-based teams, perinatal quality collaboratives, and a variety of other community partners, organizations, et cetera, who work on the ground in facilities and outside of facilities implementing patient safety bundles. Patient safety bundles are not new guidance. They are best practice guidance for specific clinical conditions, such as hemorrhage, hypertension, and the things that we know actually cause harm and sometimes death to pregnant and postpartum people. The bundles that we are working on presently in AIM really do extend across the care continuum in a way that the earlier bundles did not. For instance, cardiac conditions and obstetric care, which was released this month. I share that because I think it's very important that sort of historically some folks have known AIM to be hospital or labor and delivery unit based, but cardiac conditions generally tend to impact people up to a year postpartum, and we know that they also disproportionately impact Black and Indigenous people. So there is a real focus in the work that we're doing on both reevaluating our existing materials and then looking at how we move forward, spanning the care continuum. While it's traditionally, I think, thought of as a maternal health program, as the name would indicate, it affects people in planning next pregnancies. The impacts of their birth affect them across the lifespan, and we recognize that. I think another foundational aspect of AIM that has evolved and grown in the last few years is a focus on equity and recognizing that equity is not a separate endeavor from patient safety and quality improvement. I own that I'm a quality improvement geek from way back. Everything I do is an improvement cycle to see if we can do it better, including grocery shopping. So I own that that's the tool that I know, but I see bundles as a tool as well. A patient safety bundle is not the solution, it's a tool to move towards that. And so it's critical that we include equity in that, not as a separate endeavor, not even as a separate bundle. So what we've been doing is taking those patient safety bundles that some may know and some may not, and integrating concepts of equity and respectful care into all of them. For instance, when we talk about data, are we disaggregating data by race and ethnicity? There's a lot of different ways to look at these processes and to roll equity in as a fundamental concept, and that's part of what we're working to do in AIM. We're very excited to be expanding those supports to state-based teams. That's one of our big focuses over the next year in particular. Today is the first day of our fiscal year 4 of our 5-year agreement, and where it's clean slate, very excited. But part of what we're working on is both getting the word out about what AIM is out in the communities, making sure that the community voice is present when bundles are being developed, having patients and those with lived experience being able to give feedback and input on that, and then also amplifying the work and the outcomes that these state teams are having on the ground, both successes and barriers, to allow people to learn from each other and have those connections forged. I could talk about AIM all day, I do, but I'm gonna enter in the chat here is a link to our website, and please stay tuned. We have some social media coming about this year that didn't exist in the past. I would say WIPSI is a little more developed than we are with their fabulous video you all saw, but I am very excited about the work we're doing and however we can best support that continuum of care in the future. So thank you.
Thank you, Christie. Appreciate that update on AIM. A lot of people have heard about it. I think a lot of people don't know the details that we've talked about. Let's go next to Naomi.
Good afternoon, everyone. My name is Naomi Clemens, and I don't represent an initiative, and I don't represent a program. I represent just one perspective, and I also want to kind of circle back to one of Kay's slides, because it was one of your first slides, Kay, where you identified what you believe. And that's what I represent, is kind of sharing with you all my beliefs. There's so many things on that slide that I agree with. I agree that data is biased. I agree that clinical practice change, quality improvement, and individual behavior change are not going to remedy the problems that we're seeing and are not alone going to improve the health outcomes that we need to see and bridge the disparities that people of color are experiencing on a daily basis. I want to lift up communities and community centering. A lot of our work, we say we're centering. What I'm realizing through my 20 plus years in public health is we say we're centering, but still their voices, community voices, are not being heard. I was on a call earlier today with a Healthy Start program that was doing some phenomenal work that was completely outside of the box of what we would typically think of in public health. They were working with a housing authority. And public health is one of those initiatives that I am inspired by because their work is community-based and it's ground truth. But this program partnered with housing authority. They went beyond making a referral. Referrals are now becoming transactional in the world of social determinants of health. And my aspiration is that we move from transactional referrals to actually partnering and doing systems work at a meso level and developing meaningful and productive partnerships with these non-traditional stakeholders like housing authorities and really ensure that services are wrapped around and integrated. And we need to redefine what access means for people of color and for women of color. A food voucher is not necessarily access by giving it to them, given their competing priorities in their life. I think that's really all I want to say, Kay, and I know there's other questions, but since I'm just representing me, I don't want to go on and on.
Thank you, Naomi. I appreciate that. And we'll look forward to more of your input in the cross-panel discussion. So, Lakeisha, tell us more.
Sure. So, I think I have the fortune of coming last after the other panelists that I'm happy to join today. In that, I'm supposed to talk a bit about financing, right? And, how that makes all of this happen. Over the last several years, there have been a number of investments and initiatives focused on examining strategies to improve care delivery and ultimately health outcomes. Kay mentioned a number of efforts over the last, number of years. Many, however, kind of propelled, at least by the federal government, by the Affordable Care Act provisions. Kay mentioned that I work at CMS, and we focused on laying the foundation of an infrastructure to really kind of assess it within the Medicaid program, but certainly across the health delivery system more broadly, those quality measures that would help us to assess, what does it look like on the ground? How are our systems performing? And, so we have that foundation. I think the other components that have happened over the last 10 years or so have related to the care delivery models, and I'm at home, so that's the dog. The care delivery models that have been put in place to improve access, improve care delivery more broadly, kind of improve the coordination. Recently, the Center for Medicare and Medicaid Innovation funded grantees to look at the maternal opioid use model, or to develop strategies within the maternal opioid use model. While that is focused on opioid use, it really provides the opportunity to look at infrastructure, to look at the data systems that are necessary, to look at quality measures, to think about what, I think Naomi mentioned social determinants of health and integrating with housing and other non-traditional agencies. It provides that foundation. Certainly, the expansion of postpartum coverage in Medicaid is another one of those really important levers. However, there's still much more that needs to be done. We need to advance the measures that I mentioned, to look more deeply at equity, to look at how changes that have occurred in terms of quality, how they're affecting individual subgroups of people or specific subgroups of people. Certainly, we've seen that there have been, with the expansion of coverage, that we've seen improvement in health and health outcomes. But when you look a little deeper, sometimes the data does not show that all, kind of boats have rise with the tide. So what more then do we really need to do? Financing is certainly important so that we can create those strategies, the infrastructure, the coordination that needs to happen between all of these various parts of our ecosystem. It's certainly not just about healthcare. It's really, all of those things that impact individuals and ultimately kind of impact what those outcomes look like. So I think we are at a new frontier at the moment with particular emphasis on equity and looking at disparities. And so I think it's time for us to think about, how we put the dollars in those places that will help to further advance those initiatives. I'll pause there.
Thanks so much, Lakeisha. Well, I think everyone who's in the audience now knows why we are joined today by these individual women leaders and all that they represent. They each have a lot more to say than they were given in the 5 minutes that they were allowed for the opening of the panel. And we're now going to just try to look at and cross-fertilize some of their ideas and their knowledge around a few questions. So I guess my first question, just given where we are and the focus of the meeting, is about, thinking about the Preconception Health and Healthcare Initiative or the other movements that I mentioned. What progress have you seen? What progress excites you that we ought to be carrying forward? Obviously, Women's Preventive Service Initiative one, but tell us a little bit more about how the things that you've talked about, reflect progress and things that we need to carry into the future, the sort of build back better idea. I'd like to go first, Diana?
Sure. Well, what progress? I am so pleased, and I saw my name in a couple of your slides as to people that have been in the preconception health movement from the beginning. And I can honestly say I have been there for a very long time, since it was an idea and a vision. And I can tell you from Dr. Jeannie Connery's presidency at ACOG that her vision was every woman, every time, and really women's health across the lifespan. And so what progress has happened is I am so pleased to see that the Women's Preventive Service Initiative has actually become a reality. And now that we're in our second grant area of 5 years, so we have 5 more years, so it'll be 10 years, we're moving along and really trying to promote women's health preventive services, because so much of the time we're focused on treating disease instead of preventing disease. And so this is the opportunity to do that across the lifespan. So for me, I've seen an immense amount of progress. I've been at the table with you, with Sarah, with a lot of the long-term players, and it pleases me. We've come a long way, but we still have a lot more to do.
Thank you for mentioning Jeannie Connery. She certainly did help all of us see how this could become reality through her practice and her leadership at ACOG. What are others thinking about progress going forward? What are we building on from this preconception movement going forward?
Hey, I'll jump in and just share what I'm excited about. I'm very excited about the language of preconception and health and life course approach being used at the same time in conversation with each other. It is comforting to me because I feel that is where the hard conversations of racial equity and reproductive justice is going to take place. And the issue of access and exploring more deeply and more profoundly what access looks like. It's also important to me because Life Course is about the next generation, and that we know that this generation of women and birthing people are going to be impacting the next generation. So we need to make an investment in communities and how systems and structures are affecting them. But I'm just really excited about how preconception health and life course is being lifted up again. I feel like it's had its peaks and valleys, and it's coming up again. And that, the Maya Angelou quote that you showed, what's done is never done, because social movements is changing our context every day. And that means that we need to do better every day. And we need to be thinking outside of the box.
Thanks, Naomi. Others?
How do you follow that, right? So we do have to continue to build on what we have done, in the past. As I kind of left off, I think we're at this moment in time where we can have the conversations more openly. I think that's really important. When we can talk about and point to the issues that impact women and birthing people, and kind of that life course perspective, having that open conversation and thinking about how that factors into and can be addressed by policy. So I think the openness of the time, I think, is what is exciting for me at the moment. The bright minds now need to kind of come together to think about, how we take what we are hearing in terms of lived experiences, as well as, other parts of our system, and, kind of shape what the next frontier looks like in terms of covering care, incentivizing appropriate care, ensuring that training includes all of the things that we've talked about, so far today.
You want to jump in on this question, Christie? Do you want to wait for the next one?
I'm happy to jump in just briefly, and sort of recognizing that I wear more than one hat at ACOG. I'm taking off my AIM hat to talk about policy for a moment, which is to say that I think that one of the benefits both of the programs that have been discussed today and some of the innovation that's been discussed today is you are all absolutely correct. QI is not going to fix this quality improvement. Either is purely focusing on social and structural drivers of health, either is purely focusing on data. It all has to be so integrated. And I think that's one of the pieces that I found sort of magical in the work that we're doing in AIM, that we're able to bring people together, because when we bring them together, we're talking about patient safety bundles and implementation. But what happens is those conversations evolve. I wouldn't even, it's not devolving, it's evolving into where we're talking about policy, because to the point of, I believe there's a message in the comments that we'll probably circle back to, but talking about like the differentiation in coverage just from Medicaid program to Medicaid program, that's something that a lot of providers aren't even aware of. They know what's covered in their silo, to use the word that I think gets overused. We just know what's happening in our little neck of the woods. And I think some of the magic happens from policy, from centering those engaged who should be engaged, who should be telling us what we need to be doing better, by bringing folks together. And I think that that's one of the magical pieces of looking at preconception health and the rest, that it is a continuum across the lifespan, but we also can't fix it with one piece in that continuum. It really has to be integrative. So.
Absolutely, thank you. So I want to pick up on Jackie's question for a moment and then come back to some of our other panel questions. But Jackie, if I understand your question correctly, it's really about insufficient reimbursement, because I don't think they would ever say they're partially paying. They would just say they've set a rate. And what we know is that Medicaid rates are below Medicare rates and below commercial payer rates. And they are below, often providers tell us that they are below cost, not just the usual and customary rate that the provider sets, but that they are in fact below cost. So this inadequate, insufficient payment rates, thanks for the affirmation, Jackie, that we got this right. Again, when I was the chair of the Secretary's Advisory Committee, the committee kept trying to put a recommendation about Medicaid payment levels into our report to the Secretary, and I just had to remind them, I mean, really almost quarterly for 2 years, that the Secretary is not in charge of Medicaid payment rates, and there really wasn't much the Secretary could do about them. And so it is a core dilemma. It is a battle that I think that providers and providers associations help us fight on a state-by-state basis. I think if we can have consumers understand that sometimes a service isn't offered because the person isn't going to get paid or they can't afford to offer it, it shifts the focus more toward the policy and less toward frustration and anger with the provider themselves. So I think consumer education around the advocacy and policy context, and really having us understand, you know, if we think about the whole, that, you know, that larger construct of saying, you know, that there are social and political factors that are driving these inequities, and this is one of them. Lakeisha, you've seen this up close and personal. Anything else to be said about Medicaid payment rates?
Yeah, no, you know, that variation is very real, you know, from the types of pumps that are fully covered, you know, and to those that are only partially covered. And I think you kind of hit it on the head with, you know, there's that variation. And I like what you said about shifting, shifting so that it's not seen as the provider, you know, not wanting to give, but there are cost implications. I would also say that we are in this time, you know, kind of coming out of, or maybe we're still in, you know, I don't know if we're coming out with the variants, where we're back to more people needing coverage in Medicaid, and what that really means in terms of the expansion of, you know, some of the various elements of, you know, durable products and those kinds of things. And I think we're really, you know, states are going to become and are, you know, becoming a little bit more strained again. You know, certainly these things kind of go through these cycles. And so, you know, there's a time when, you know, that is, we're in a time, you know, I think that it's tough on state budgets. And I think coverage, you know, kind of giving that baseline coverage to more people is in the short term really important, and perhaps a little bit more important than some of the individual pieces, unfortunately.
So we have 2 minutes left, and if any one of you has a 30-second action statement or closing statement you want to share, now's the time. You want to jump in? And I'm gonna signal. We could, while we're doing that, we could see our graphic illustration of what does Rio think we said.
I have just two things to say, okay? And it's really based on a conversation I had earlier in the week with a dear friend and colleague who reminded me that public health is what we as a society do collectively. And that I agree 100% with what you said, Christie. It's all of these things together that will make a difference. I just wanted to make sure that we lifted up the community contextual factors, but it is our collective action that's going to have the impact.
Thank you so much. Rio, go ahead and post.
Yep, and this is Anna, and I just wanted to piggyback on what Naomi just said and just really emphasize that, you know, even if you do see a healthcare provider, sometimes we only have 20 minutes to cover everything. And so health is really outside of the provider's office. It's in the community, it's with our partners. And so we all have to play a role in promoting health and promoting, you know, good behaviors, especially with COVID. We realize that, you know, a lot of the Well Women exams were put on hold, but we need to promote and reinforce what the healthy behaviors are and what visits should be kept if you have a chronic disease.
So Rio has been drawing in the background and giving us some graphics about this. And I just want to thank our panelists and say each of you is appreciated. Happy to learn. I learned more about your work. I'm sure others learned more about your work, that you've given this time to the meeting and to this panel is really very much appreciated. Rio, do you want to say anything about the graphic, or should I walk through it?
Please feel free to walk through it.
Okay, so thinking about, I love that, you know, preconception reflecting, you know, that evolution with the systems change and the equity and gender justice and more, and then about thinking, you know, across the areas with the Women's Preventive Services Initiative and what Diana shared with us with AIM, and thinking about how we're integrating equity into those patient safety bundles and getting them out into the community, and about financing using our levers, and having a new frontier on equity that we heard from Lakeisha, and then thinking about overall the role of consumer education and engagement in policy change. We need our consumers to be advocates. We need them to be self-advocates, as we heard on the last panel, but we also need them to be advocates for policy change. Many of you know, and you can't read this, but I have a sticky note I have been using the entire pandemic, which says advocacy may be as important as self-care. We've got to do both. And so our collective action is what's going to be making a difference. And we are, I'm sure that Rio's drawing will be shared again. Claudia is asking me a question. I will say it's a little blurry on our screens right now. So I turn it back to Eilish, to Sarah. Thank you for letting us go a minute over.
Hello, everyone. It's Shamika here, and I want to take this time to say thank you to all of today's speakers, and especially to Kay for hosting that wonderful panel. I don't even know if I'm supposed to do this, but I just want to say you all were amazing. Thank you, Diana, for introducing us to WPSI. Had never heard of it, but I definitely will be checking it out now. Kay, I love the quote on advocacy may be as important as self-care. I hope you don't mind. I got a sticky note now. I'm gonna have to add that to it. And Naomi, your quote around our collective action is what will make real impact. I need to get that somewhere and blow it up so it can like hang behind me. So anytime I'm in a meeting, anytime I'm talking to someone, like that is there. Like it's going to take collective action from all of us to create that real impact. So if you're like me and clearly really eager to talk about all the things that we have heard today, and just to share your ideas on how you want to move the vision forward and talk about the things that you've heard, please feel free to click on the link that should be in the chat that will take you to the Zoom room where we will talk about some of the awesome things that you guys have posted on the Jamboard, as well as things that maybe you haven't had time to post on the Jamboard. And this will be short, about 20 minutes. So you can feel free to pop in, say hello, stay the whole time if you like, or pop back out. Also, as a reminder, we have recorded today's session. That's right. You get to rehear all of these amazing conversations from these dynamic individuals at any time that you would like. So please be sure to subscribe to our newsletter so you know when this becomes available. And also, we will be making sure that you all have availability to the graphics that Rio has created. And thank you again, Rio. These have all been so amazing. And last but not least, definitely, I want to thank you all for showing up. I know some of you are in places where there are huge storms. Some of you are now dealing with the aftershock of some of those storms. Or it's a Wednesday, it's hump day, and we're almost a Friday Junior, but not quite there yet. So we appreciate you all for choosing to spend your Wednesday here with us. And please don't forget, there's another great day ahead tomorrow, full of some more dynamic speakers, more dynamic topics, all about how we're going to continue to move this work forward. And with that being said, I just want to turn it over to Eilish.
Hey y'all, so I'm just like super souped up about tomorrow just because Shamika just played this violin for us and just like ushered us to our registration for tomorrow. Make sure you guys are signed up, please. We would like to see you. We would like to hear more of your thoughts and your ideas. Thank you for joining us today, and please do not forget to go back to the toolkit and access the evaluation form so we can know how we did. So you can just give us some feedback on the overall session, and we'll greatly appreciate it. Tomorrow's session begins tomorrow at noon Eastern. So thank you so much for joining us today. And also please be sure to check the chat box. You'll see the link to the breakout sessions where you can talk to us a little bit further and deeper and for a little while longer in case you just don't want to go yet. We're not pushing you out. You guys can come hang out with us for a little while longer. So thank you.
Hey, Alice, just want to let you know that I'm gonna head on over to the breakout room.
No problem.
Alicia, I'll keep you company for a few minutes while I'm noticing the participants going to the room.
Okay, good. I wasn't sure if you were to click that link as well.
Figure we can give, we'll give people a few minutes to just kind of get up, just in case they are looking for the link, and then we'll go.
Okay, cool. Sounds good.
Great. That was so great.
All right, guess we could go over there too.
All right, see you in a minute.
All right.
Thanks, Thaddeus.